Hello, my name is Antonio Torres, and this is my final presentation for my medical terminology class for Colorado Christian University. I am working towards my degree in healthcare administration. This presentation is going to cover just a quick summary of the medical terminology class, what I've learned, what I knew, how I'm putting them both together, and just a short breakdown of each session, and then finally how I am going to use this information, which I have known, which I have learned, how I put it together and use it in my career as a healthcare administrator. So session one, we covered some common medical error mistakes. The example we were given was if it was okay to go ahead and just chart the patient has a rash. Obviously, you would not want to go into your physician's office and see something like this in your chart, because you would then wonder, did I receive the proper diagnosis? Did I receive the proper treatment? And what are the credentials of the provider that's treating me if that's all they are doing, or that their staff is doing, and they're allowing the staff to continue doing so? Medical mistakes, they happen, probably more commonly than one would think. And this could be due just to a simple oversight, is what I covered in my paper, is a patient with a similar name, and I believe the name I used was a Mr. W. Smith, and one of them I gave the date of birth of January 1st, 1980. The other one was January 10th, 1980. So you can understand you have two W. Smiths. However, you also have them both being born in January 1980. However, one was born on the 1st, the other was born on the 10th. When you're in a fast-paced medical clinic, maybe you're in an emergent situation, let's take this current COVID situation, for example, and you've got multiple people coming into the ER, one after another, one after another, one after another. You get two W. Smiths in there with these similar birthdays, it's very easy to get them confused, and mistakes can happen and do happen. It's not because the nurses or healthcare staff, providers, or anybody are intent on doing such. It is just that it's human error. And this is why my third point here on this slide, communication is a major aspect of healthcare administration. So just like we expect the front desk staff to communicate with the nursing staff and triage staff, ancillary employees, whoever the patient is going to see before they see a physician, a healthcare administrator needs to have a good form of communication with your staff. You're going to need to be able to communicate in terms that they use on a daily basis when they're treating patients and when they're communicating with providers and other ancillary staff. So, for instance, at the facility I work at, the emergency room needs to be able to contact clearly and cohesively with the radiology department, which is right next door. They also need to be able to communicate clearly and efficiently with the units that are upstairs if the patient is being admitted. The emergency room doctor needs to communicate clearly and efficiently with the hospitalists that will then resume care of the patient once the patient has been admitted, and they will then be the primary medical provider for that patient during that stay. So as you can see, my fourth point, there's many interdepartmental cogs that come into play. Everybody has a situation, a piece where you are very important in this medical field and how it works. The organization is what I should say, not field. The second session that we discussed was just a reflection of ourselves. I was a medical assistant for 12 years, so I take my experiences as a blessing. I've had some good, I've had some bad. I don't let any of it knock me down. What I do is I have learned to engage with newer employees, newer medical assistants, and learn to ask them questions and not just brush them off as a rookie or the new guy, as some people would do. and have found that I learn a lot from somebody who is new, because maybe they have a different outlook on something that I didn't look at it the way they look at it, and I can then learn and develop my practice and my methodology to be better for treatment of the patient or treatment of our customers, however you want to label them. I had a physician I worked with one time. He said, "Do right by the patient." He wasn't saying to break the rules and go against everything, but what he was saying was sometimes you just have to use your brain and just, what does the patient need? Quit running down this list of things. Look at the picture. You're always told to look at the big picture, but you need to look at what the patient needs. And just learn to focus. And I think that was his way of centering himself, and that's helped me a lot in my information, in my career. Sorry. Correct usage of medical terminology. This class was a great refresher, and in my 12 years as a medical assistant, I found that correct and proper usage of medical terminology really, really helps with any communication you have with insurance companies. One little slip, one little mess up, and it can throw the whole thing out of whack. And if you are working on a prior authorization for a procedure or even a surgery, that can set it back weeks, if not just days. But if the patient is really needing surgery and their insurance is willing to pay for it, but you cannot go through with surgery if the patient does not have an authorization yet. So you're putting the patient at a financial risk if you do not communicate clearly and effectively using your medical terminology. Thirdly, we had the scenario regarding opioid dose, and the nurse forgot to chart it, so another nurse gave a second opioid dose, and this was due to short staffing, long hours. That other nurse was ready to get out of there. In that situation, I actually spoke with a colleague of mine who happens to work in our emergency room, and I have never been in this situation myself, but she said if a mistake is made, honesty is always the best policy. You can always chart late, and that's better late than never. Really, it takes that saying and makes it real. She said communication is key, and that just helped me to think that, especially during long hours and with short staff, not only does it make you accountable, but then your coworkers can turn to you and say, when you're wrapping things up at the end of the day, "Hey, did you remember to get the charting done on Mrs. Baker or on Mr. Smith? Did you remember to give them that ice pack," or whatever the case may be? It'll keep you honest. It'll keep you accountable, and I think as a healthcare administrator, that is something that I would need as well, because I am not somebody who is going to be upset or be hurt if one of my subordinates that I'm a manager over were to say, "Hey, Tony, did you remember that you were going to do this?" Because that helps keep me accountable, which would make me a better manager for them. I'm not going to go home and stress out and think, "Oh my God, I forgot to do this." And then, when I go back to the emergency room nurse that I spoke with, she said that a majority of mistakes, no, not all of them, but a majority of mistakes, depending on the severity, can be used for a learning opportunity and not just disciplinary. She said you would get written up, but that the situation is then taken and turned around to a learning opportunity so that you can grow from it. They want to help you grow. They want to help you become a better employee, whatever department you're working in. Now, in session 4, I had the privilege to interview a former manager of mine. And all I can think of after interviewing her was that, I reflected on how many times I would see that she would come to the clinic and she would interact with us. And you know, granted, she wasn't your best friend, but she would be a friend to you at work. Um, and she was firm when she needed to be, but as my last point says, she was not a drill sergeant. She was able to be present for us, and we knew that she was there for us, and we were able to go to her with any questions, concerns, situations that may have come up. And what I could think of that was just going back to my first point. I could just take those good traits with me onto my career and remember, hey, this is how so-and-so did it. This is how I want to do it. Now in session 5, Professor Thompson, you asked us to go ahead and, you know, say a little about you know, what we want to do, how we are going to make ourselves an asset in our medical organization. And I think what I want to do is just be somebody who's very fluid. I don't want to be concrete. Like I said before, I want to be able to learn from the new people, take from my experiences and add to it, and kind of be like that. What is that? I think it's called the Amish friendship dough or whatever it is, and how you just take a piece of it and you let somebody else have it, and it just grows from there, and they can keep making bread and so on and so forth. That's how I want my career to be, is I'm taking and giving and having my lump of dough grow. So I appreciate everything that I've learned here at CCU so far, and I've been given a great foundation. I appreciate the refresher you've given me in this medical terminology class, and I can see where, and I have thought of many aspects that I am going to have to be using my medical terminology in the near future. Thank you very much.